Right. Thank you for staying. I'm afraid I've not got anything exciting as interactive voting or fluffy bunnies, but I've prepared a brief presentation about plasma cell myeloma, which is the most recent addition to our residual disease programs. So I'm going to give a bit of background into plasma cell myeloma and minimal residual disease, run through some of the findings for 2 pre-pilot studies that myself and Stuart Scott have been working on, and run through some of the findings of the current first distribution for the plasma cell myeloma program. Now, many of you will have become aware of this program a few weeks ago because in a moment of pre-holiday hysteria, I clicked send on an email and suddenly notified over 3,500 participants that their samples were on the way. So I apologise to anyone that I gave the shock of their life to. It was intended only for the registered participants. So, plasma cell myeloma. As with acute myeloid leukemias, it's a pretty heterogeneous, heterogeneous family of disorders known as the plasma cell dyscrasias. But what the underlying feature of all these conditions are is they're associated with the proliferation of a single clone of plasma cells. Now, that's typically found within the bone marrow. You do occasionally find them circulating in peripheral blood in some conditions. But as you would expect, plasma cells being your monoclonal antibody producers, if you've got clonal proliferation of plasma cells, you are also going to get proliferation of monoclonal paraproteins, which manifest themselves in the serum and urine. So, plasma cell myeloma also seems to be synonymously used with multiple myeloma throughout the text and actually throughout this presentation. You'll see both terms used. But second most common, hematological malignancy, and occurs with an incidence of around 6 cases per 100,000 population per annum. Now, almost always preceded by MGUS, monoclonal gammopathy of unknown significance. This condition also occurs in around 4% of the over 50s population asymptomatically, and has a 1% chance of progression onto multiple myeloma per annum. And when it does progress, it almost always goes through this stage of smouldering multiple myeloma. This is just associated with an increased percentage of clonal plasma cells within the bone marrow, and also an increased incidence of progression. You're up to about 10%, I think, per annum to progress to multiple myeloma if you get to that stage. So these are the other members of the family, the most well known. Plasma cell leukemia, where the clonal plasma cells are circulating in the peripheral blood. Acute amyloid, AL amyloidosis, where you get overproduction of amyloid light chains, which then get deposited within the systemic tissues, renal, heart, gastrointestinal tissues. There's some degree of systemic involvement. Waldenstrom macroglobulinemia, which is hyperproduction of IgM as the paraproteins, and then Poems syndrome, which, if I can get this right, is polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin involvement or something like that. It's quite a rare syndrome, but underlying it is the clonal proliferation of plasma cells. So, MRD assessment, multiparametric flow cytometry analysis has long been the gold standard, classifying and managing all range of hematological malignancies, not only plasma cell dyscrasias. And we all know of the use of MRD assessment in monitoring patients undergoing treatment and on therapy. But recently there's been much focus on the use of MRD assessment in plasma cell myeloma as a potential surrogate endpoint for clinical trials. Now, there are lots of meta-analyses out there at the moment, and all the data is strongly suggesting that MRD negativity can be used as a potential replacement for progression-free survival in clinical trials. And these studies are soon suggesting that not only is it going to become a regulatory endpoint for these trials, but the level of sensitivity will also be set at 0.001%, so more sensitive than what we've been used to. Obviously, for this to happen, we require, as we've been hearing throughout the last 2 days, standardization, which is essential. But fortunately, we've had some guidelines recently produced, and these are two of them. We have Mary Alice's group that produced the myeloma guidelines, which covered staining and acquisition, and of course Maria's guidelines on plasma cell myeloma, which covered the analysis and reporting. So around the same time these guidelines were being produced, we were actually approached by the ICCS Myeloma Working Party back in 2015 to see if we would consider adding plasma cell myeloma to our existing range of minimal residual disease programs. And because Liam's always up for giving us new challenges, so he said yes, and I started working closely with Andy Chantry, the Royal Hallam Hospital here in Sheffield. Now, Andy runs a weekly myeloma clinic, and as he consents his patients to take part in his plasma cell studies, we didn't require further ethical approval to use the waste material from the patients for his clinic. So we started working on stabilising the bone marrow, and then working with HMDS in Leeds, who very kindly did some off-site testing for us as well to assess suitability of the material. And once we were happy with the way that the samples were looking, we recruited 8 centres that were experienced in MRD plasma cell myeloma assessment for a small pre-pilot study, just to see what the samples were looking like out in the field. So first distribution, we deliberately made it to look like the anticipated MRD program was going to run, with 3 samples, 1 of a reference sample and 2 which contained myeloma cells that were representative of the levels you'd find in MRD. Now these were composed of the stabilised bone marrow from Andy's clinic, but we also used a background of peripheral blood stem cell harvest material. Traditionally we've used peripheral blood, but we wanted to try and mimic post-chemotherapy transplant background. So this material came from our local apheresis unit, and these were patients that were undergoing an autologous stem cell harvest. So they've been treated with granulocyte colony stimulating factor, so the blood should be rich in CD34 progenitors and a few hematological progenitor cells as well, which is the closest approximation we could think of to bone marrow without actually bleeding somebody dry. So, findings from the first small scale study, we had 8 participants, and as you can see, just 4 panels were being used. The guidelines recommended that CD138, CD38, 45 and 19 were essential in every tube, and that 27, 56, 81 and 117 should also be tested. So we had consensus, as you might expect from an expert group, with the exception of the 2 centres that didn't include CD81, pretty much 100% consensus there with the markers being selected. So some agreement on panel design, and a total of 17 different antigens being used. Now if you look at the number of events counted for sample 1, those range from 500,000 all the way up to almost 4.5 million, and slightly higher for sample 2, from 1 million up to almost 6 million events. So no problems in collecting the number of events required for the level of disease that was in these samples. and I'd manufactured these samples to have a value, median value in sample 1 was to be 0.04, sample 2 0.02, so the median values quite accurately reflect the anticipated level of the samples. Now, there's some degree of consensus. Anyway, there's a cluster of results at the top there that are showing good consensus, and you've got a few outliers at the bottom. But for a first send out, I was quite happy with the quality of the samples that we issued. So we went on to the second stage study, recruited the same 8 centres, but we also required 2 additional centres for this stage of the study. And I wanted to have a look at linearity on this occasion. So created a range of 5 samples. The first one containing no neoplastic plasma cells, second 0.1, and then a 10-fold dilution all the way down to sample A. This time, we asked the same information, percentage neoplastic plasma cells and the number of events required, but we also asked for some antigen expression in terms of positive and negative, and also staining intensity, as Alison's just been talking about in her presentation, and a few questions about methodology and instrumentation. So these are the findings this time in terms of antibody panels. We recruit 2 new centres and find ourselves with 2 new panels, but those markers were in consensus, so slightly less consensus this time around, but all of the markers that are recommended for use in every tube are still being used there. So this is a table adapted from Maria's paper, actually. If you're reporting MRD, it's always useful to specify your detection limits and quantification limits. And this table just outlines the number of cells that you need to be analysing for those particular levels. So if we can just have a look at the number of events that were being collected for that range of samples that I issued. For sample B, where there's 0.1% neoplastic cells, no problems whatsoever. 300,000 events is more than enough there for that level of neoplastic disease. Sample C, you're looking at, you want 300 to 500,000 as a minimum. So again, I'm happy with sample C, which is where the current level of sensitivity is at 0.01%. But if you get down to D, where you wanted to collect 3 to 5 million events, there were only 2 centres that were collecting sufficient number of events there. But I'm reasonably confident if we issue a greater sample volume for those levels of neoplastic cells that we should be able to hit the magic 3 million mark for most of the participants. Now, David showed this slide yesterday as part of his presentation, but just to run through it again, these are the results summarised for that second pre-pilot study. Sample B, C and D, we had 8 returns and they showed pretty good consensus. Sample E, as you would expect with the lower levels of disease, there's a much greater range of variability. Now this also highlights an issue of calculation error, which are represented by the coloured dots. The red dot was a factor of 10 out, but once corrected, sat in nicely with all the other results. And Liam's going to cover calculation errors further in his presentation, which follows on from this one. The results in the red oval, they showed an example of a systematic positive bias. That was the same centre, and each result was occurring over the 75th centile. And also on there, we have the current guideline requirements and the predicted future requirements. So in terms of positivity and negativity, reasonable consensus, certainly 38, 138, 56, 45, all participants were reporting at 100% positivity. But when we looked at the staining intensity, which is what Alison has just covered, there was absolutely no consensus whatsoever. So much as Alison is going to introduce this method for the leukemia programs, it's something we're also keen to investigate with the MRD programs. So to sum up the pre-pilot, we are able to produce samples, considerably more difficult trying to get them to look like regenerative marrow, but we're getting there, and we're always tinkering with the methods to see if we can get it to look better. We've now transitioned into a non-accredited program which is open to all, and I actually sent out the first samples a few weeks ago. That trial should have closed last week. It's actually still open. I'll close it when we get back into the office later this week. But I just wanted to run through some of the findings from that so far. Early last week I had a quick data fall. There was 18 submissions, so we'd had 50% returns by that time. And just to run through a few of the questions that we asked, just currently using SurveyMonkey, which just gives us a little bit more flexibility in the questions that we can ask participants when we're developing a new program. So most participants are using 8 or more colours, and that corresponds to this number of tubes being processed, 1 or 2, although there was one centre that was still processing 10 4-colour tubes for plasma cell myeloma. As you would expect, increased number of participants increases the number of variations of panel design that you get, so we're now up to 11 different panels being used, but surprisingly, same level of consensus pretty much. I strongly suspect that panel number 11 is omitted to include CD38, in which case it would be the same level of consensus as we saw with the first pre-pilot study. We asked about denominators being used, and the majority, 2/3, were using all bone marrow nucleated cells. Now, if you read the literature, all bone marrow nucleated cells as a denominator is supposed to give you results that are more comparable to molecular genetic techniques. However, it does have the disadvantage if you are using harsh lysing solutions such as ammonium chloride, you are going to lose some of your nucleated red cells, which can affect your percentage MRD. So some people prefer to use total leukocytes. Doesn't seem to be much in it, to be fair, and it seems to be a matter of personal choice. These are the findings so far from the study, and again, I'm quite happy with the consensus on both of those samples. They were manufactured at 0.1 and 0.05%, so median values returned so far are reflecting those target values. There are a couple of outliers there, and I deliberately made these samples with a higher level of residual disease for the first send out, so no problems with the number of events that were counted. Again, 100,000 is sufficient for the 0.1%. I would ideally like to have seen more collected from that as a minimum, but up to 6.9 million events were obtained, and up to 7.2 million on the second sample. So as I mentioned earlier, I think if we increase the sample volume for participants, then I can't see any reason why we shouldn't be able to issue samples down to a 0.001% level of sensitivity and get some meaningful results. So future developments. I'd like to carry out further studies with the initial expert group, possibly concentrating on that new proposed target value, and see if we, as I mentioned, increase the sample volume to get more consensus. We'd like to perform some investigations of issuing samples of patients that are undergoing monoclonal antibody therapies, and we'd also like to issue a few electronic trials to study gating strategies for the plasma cell myeloma program. But that is as much much as I've got, I'm afraid, at the moment. So thank you for your attention.